I love giving these talks anytime that you've been able to get data from a research study that you're passionate about, and then you're able to talk about that data and the findings. It's always a really, really fun time. So I'll be talking about the Prevent Anal Cancer Self-Swab study today. And as Sandeep mentioned, with cervical cancer screening, self-sampling has been approved, but not at home. The self-sampling still has to occur in the clinic. I think that and of course there's large government NCI-driven studies going on now, looking at home-based self-sampling, and if that can be added as an option. Ultimately, I think that's what we need. We need options for people. People are coming from all different spaces. And if there are options for them to get involved in screening, I think that's where we're going to have the most success. Okay. Oh, these are my financial disclosures. First of all, thanks to the participants of the Prevent Anal Cancer Self-Swab study and also our Community Advisory Board. Our clinics up on the left that were scattered throughout the city, who are our partners, where persons in the study could go to get a clinician sampling if they had been randomized to that arm. Staff on the left, co-investigators there in the middle, and then our institutional partners on the right. So what I want to do is make sure that we're all on the same page about the epidemiology of anal cancer, and then I'll get directly into the PAC self-swab results, and we'll spend the rest of the time on that. I think that the census here is small enough that it may be okay for you to ask questions as we go through, rather than saving it until the end. If we do get behind on time, then I'll step in and make a change in that too. Okay. All right. So we'll talk first about after the epidemiology, self-sampling specimen adequacy. It doesn't help if persons like self-sampling, but if they're not able to do it, so you get an adequate specimen, it's a real problem. What their preference is for that kind of sampling, and then finally, what does it mean for disease detection? And does it help us increase the likelihood that we will detect individuals or find individuals who have high-grade lesions at the anal canal? Almost all anal cancers are caused by human papillomavirus. It is sexually transmitted, very, very common. And it's also a transient infection. If you're familiar with cervical cancer screening and cervical cancer natural history, you know that most of those cervical HPV infections are transient. They won't be able to be detected in a few months, a year, maybe up to 2 years. And it's the same way with HPV at the anal canal. Sexual transmission with cervical HPV, virtually all of those cases, but not all, but most cases are the result of a penis transmitting HPV to the cervical vaginal bulb. In the same way, with this, we have penis transmitting HPV to the anal canal. So same kind of mechanism. Okay? I think it's important to state, though, that when people who are diagnosed with anal cancer are asked about behavior, there is a substantial proportion that do not acknowledge any anal intercourse in their entire lives. And still, they're being diagnosed with anal cancer. They're not acknowledging anal sex in their lives. Certainly, there's a lot of stigma around that, and this is a huge thread that goes through this entire talk, is stigma around this kind of screening. But nevertheless, I've talked to too many heterosexual men who have been diagnosed with anal cancers, and I don't know why I have this. So I think that there's certainly other pathways that are possible that we just don't know very much about. Low-risk types cause the condyloma that you see on the right-hand side. High-risk types cause a variety of different cancers. Cervical cancer is the most important outcome of HPV infection, but also oropharyngeal cancer, and also anal cancer. People with HIV have a much, much higher risk for anal cancer than do persons who are HIV negative. So this heat map of cervical cancer incidence around the globe, of course, there is dramatic difference in the incidence. The light-colored countries are where the incidence is lowest, and then the dark blue is where incidence is highest. In terms of this distribution, what comes to your mind in terms of what causes this kind of difference in incidence? Lack of resources, lack of opportunity to do screening for cervical cancer. What else? I'm sorry? Medical infrastructure, kind of linked with what I think I'm hearing here in terms of, are there resources there? Is there an opportunity that an individual could screen if they wanted to? Yeah. What else? HIV prevalence, possibly. There's certainly increased risk for cervical cancer in a person with HIV. What else? Yeah. Maybe the individual doesn't know that they're at increased risk for cervical cancer. Maybe the healthcare provider, if they've been able to see a healthcare provider, didn't recommend a screening. We know that's crucially important for all kinds of screening, is that if the healthcare provider recommends, the patients usually say, okay, I'll do that. Not always, certainly, but it's a really important thing. So some other potentials. Well, actually, look at incidence here. So in North America, you see incidence is 6.3, 6.6. This is for cervical cancer per 100,000 persons annually. Whereas in sub-Saharan Africa, we see 26.2 in Nigeria, 64.8 in Tanzania. But then look up at Eastern Europe and Central Europe. They don't have a problem with infrastructure for cervical cancer screening. My family's from Hungary, and I asked them about, well, why is cervical cancer incidence so high in Central and Eastern Europe? And for them, the primary answer is culturally, it's just not as acceptable here for a person with a cervix to go get screening and expose their genitals to cervical cancer screening, to a physician who is going to use a swab on them. But culturally, it's a difficult thing for Hungarian women to do that. So of course, healthcare access is huge, but also everyone's coming from a different culture, and some of those cultures have fewer barriers around this, and others have more barriers. So again, this is an important thread through the talk. We talked about healthcare access, awareness of cancer risk, lack of provider recommendation. We know that providers they don't have the time or don't have the inclination to talk much about sexual health with patients. Stigma of the genitals, sex, STIs, embarrassment about that physical exam, maybe worry about hygiene. And there's always competing health issues that can get in the way of preventive screenings. When I think of possible barriers to anal cancer screening, it's much of the same thing. But then we add layers, I think, on top of that related to sexual orientation, related to the anus, receptive anal sex, that also have tremendous amounts of stigma associated with them. And I think it's going to make it really difficult. Even though we have recommendations for screening now, it's going to be difficult to get individuals to actually go for screening. With cervical cancer screening, and as I'm sure you've heard from the work of Sadeep and the other faculty here, that when a person is able to self-sample, particularly individuals who have not self-sampled or have not done cervical cancer screening in the past, or they are under-screened, that the opportunity to do self-sampling increases the proportion of them who can get initially screened. This is an old map, but if you look at the countries in orange, these are countries that have now a national program for HPV testing, including self-sampling for cervical cancer screening. This map is from 2022. I know already that Australia now has a nationwide program for doing self-sampling with persons with the cervix. So it's definitely gaining traction, and we're going to see more and more of this. But there remains the question, a person might start the screening process, but then if they need to go to the clinic, or if they need to follow up with that, do they do that? And it's something that I know that cervical cancer self-sampling field has some struggles with, and I'm sure that we're going to have struggles with it too. Anal cancer incidence has been increasing since about the mid-20th century. On the x-axis, you can see 1975 through 2021, And then on the left axis, you see that incidence of number of cases per 100,000 persons. So you're going to immediately see here that this is a very rare cancer overall in individuals. But we still see incidence increasing in both males and females. And by the way, there's a lot of binary gender type stuff that I'll have to talk about here, because that's just the way cancer data are collected. It's where they've always been collected. And that's really, although people are trying to change that, that's still the way these data are collected. But we see increasing incidence in both women and in men. So the next slide I'm going to show you, don't try to look at it too closely. It breaks all the rules of what one should do with presenting data in a presentation like this. But I've got to show you this. So we looked at increases in mortality rates in two different periods among individuals. This is individuals overall. In particular, actually here, greater than or equal to 50 years. So we're looking at the increasing incidence in mortality from 2001, 2005 to 2014, 2018. So these two 5-year periods. Overall, Wisconsin's #1 in increasing mortality between those two time periods. Alabama's #2. In terms of males, well, let's see, let me back out of here. In terms of males, Alabama's in the top 10. Again, this is for increasing mortality rates between those two time periods, mortality from anal cancer. And then among women in Alabama, Alabama's got the top spot. This is of all 50 states and Puerto Rico and Washington, D.C. So the slide that you saw previously of those increasing rates, and that's the case overall, but as with anything else, we see increased incidence in some areas as opposed to others. The Southeast, probably in part due to HIV epidemic, and the Midwest, also due to HIV, but also smoking. Cigarette smoking is highly correlated with anal cancer as a risk factor. What you saw previously are overall rates, but here we're going to look at the populations that are most at risk. In this anal cancer risk scale, up on the right-hand side, you see a risk scale going from a blue color to an orange color, red color. Red color, that's the highest risk. Along the x-axis, you see these panels broken up into males, females, and then finally on the far right, persons who are immunocompromised but don't have HIV. So over here on the left, among males, we're looking specifically at men who have sex with men. You can see up in the up left-hand corner, those red dots, showing that by far the highest risk for incident anal cancer is among MSM who are HIV positive. And as you would expect with cancers, almost all have a strong age gradient, where the older you get, the more likely the person is at risk for incident anal cancer. So for those persons over 60 years old who have HIV and are also MSM, the incidence is well over 100 per 100,000. The current incidence of cervical cancer in the United States is about 6 per 100,000. So many times higher risk for anal cancer in that population than there is in cervical cancer overall in the United States. Lower in that panel are HIV negative individuals. And for those that are over the age of 45, the incidence is really elevated, and for older ages too. Moving over to the second panel, these are males who are not MSM. They're heterosexual males with HIV. You see there's a high incidence. Down below in the blue dots, that's what I was showing you in the increasing incidence over time graph just a little while ago, where that overall rate, it's like 1 to 2 per 100,000. That's a reflection in these blue dots here. Oh, in the third second, I'll point out a couple more things here. We see HIV positive women here, also with increasing incidence of anal cancer. For those who do not have HIV, but have a history of vulvar cancer or vulvar precancer, and vaginal precancer or vaginal cancer, increasing risk in these populations also. And then finally, a person who's had a solid organ transplant that occurred 10 or more years ago, they are at much higher risk of increase for anal cancer because they've been on immunosuppressant drugs the entire time, in all likelihood, since that solid organ transplant began. So persons who have a profoundly immunocompromised system, or it was compromised at one point, even though it may have been reconstituted in the future, still, those individuals would be at increased risk for anal cancer. Okay, so quickly, the natural history. For those of you who are familiar with the cervical cancer natural history, this is going to look very familiar to you. So we go from uninfected anal canal to HPV in the anal canal. As I mentioned to you earlier, most of those infections are transient. They're not going to be detectable within a few months, a year or two. Those that are detectable, though, it's considered persistent HPV infection in the anal canal. As long as there's persistence, there's the potential for progression to lesions, high-grade lesions in the anal canal, high-grade squamous intraepithelial lesions. Okay, these too often regress, but we think in anal cancer they don't regress nearly as often as they do at the cervix. But if you know the cervical cancer treatment model, you know that once a person gets high-grade lesions at the cervix, it's standard of care to automatically treat that individual to remove those lesions because it's known that that's a great way to prevent cervical cancer, to prevent invasion. It was only 2 years ago that the Anchor study, a study in the United States with 25 different sites, was able to prove that if you remove lesions at the anal canal, you get a similar result in that you reduce the risk for invasion, and that person is then able to more likely avert anal cancer than a person who does not have those high-grade lesions treated. The treatments in the anal canal are nowhere near as adequate, as successful as they are at the cervix. It's harder to find those lesions in the anal canal. Anal canal is folded. You can think of, closing your hand like this and all of the folds of skin that you get there. That's what that's what the clinician is looking for, lesions in those folds versus essentially a disc that is the cervix, where it's much easier to see those lesions. So there's a lot of difficulty with this, but finally, 2 years ago, we know treating can prevent anal cancer. And that's what's led to the recommendations that we see today. These recommendations start, as you might expect, for men who have sex with men and trans women who have HIV, where screening should begin at age 35 and happen typically on an annual basis. Women with HIV, men who have sex with women with HIV, and then men who have sex with men and trans women who don't have HIV, have screening starting at age 45. But then also those with a history of vulvar, precancers or cancer, and persons who have had a solid organ transplant more than 10 years ago also should be screened. Okay? You might be thinking, we've got HPV vaccination. Why do we still have to do this screening? Vaccination is fantastic. It's excellent at preventing infection as long as the vaccination, is given, and as long as the vaccination is given during adolescence. If it's given after the age of 26, it's much less effective than if given under the age of 26. Last time I checked, in the United States, the uptake of HPV vaccination in adolescents is about 50%. So it's definitely suboptimal. We need to get that rate up much higher. And then individuals can get vaccination in the United States over age 26, but how effective that's going to be it seems unclear that will have a lot of effects. Okay, so let's go back. This is the same natural history slide that you saw earlier, and this is where the Prevent Anal Cancer study comes in. We call it the PAC self-swab study. Persons are randomized to one of two conditions. Either they get a kit in the mail from us where they do self-sampling, or they're randomized to go to a clinic in the city. I'll talk a little bit more about this. But the upshot of all this is will sexual minority men and transgender women, do they prefer home-based self-sampling versus clinician sampling. Our hypothesis, after all that we see with cervical cancer self-sampling, is yes, that they will prefer it. Okay. So our objective, measure engagement with annual screening for anal cancer, and also then the factors that are associated with those who do annual screening, which means we're not talking just baseline screening, but also then following them for a year, asking them to screen again. Cancer screening is typically a repeated affair. So we want to know, okay, well, what's the proportions that we'll do repeated screening? Greater than or equal to 25 years of age, a Milwaukee resident, part of the inclusion criteria, sexual minority men, either cis or trans women, Spanish or an English speaker. These are some of the recruitment materials that we used in Milwaukee. You know, there's a lot of stigma, right? And it was important to try to get people into the study that we needed to be a little bit lighthearted about what we were doing. And I think that some of this was successful, but still, recruitment was quite difficult. Exclusion, if a person was using anticoagulants, because there would be biopsies at the end of the study, they were excluded, and persons with a prior anal cancer diagnosis were excluded. So to give you a sense of the activities, when a person saw one of the recruitment material, there was a QR code that was associated with it. They could go online with that and take an eligibility survey online. If they passed it, they left us their name, email address, and telephone number. And we contacted those individuals and set up a time to do consenting with them online. If they consented to the study, then we asked them to do baseline survey. If they did the baseline survey, then and only then would they be randomized. So all of this up to this point is done online. We've not seen any of these individuals except one or two who preferred to be face-to-face to do the consenting rather than doing it online. So persons are randomized to the home-based self-sampling or the clinician swabbing. In the picture at the top, this is the kit that we sent into the home, very rudimentary. Our instructions, though, were not rudimentary. They were helped developed by our community advisory board. They were focused and targeted on the population. Here is the swab that was used. Underneath the swab, there is a vial of standard transport media. So the individual did the anal sampling, put the swab in the vial, broke it off, put the top on, put it back in the kit, and then sent it back to us through the mail. Underneath the blue gloves there's a temperature recorder. We were interested in whether or not these kits being exposed to high temperatures, left on the dash of a car, or the very low temperatures of Wisconsin, whether that impacted the adequacy of the specimens. At the bottom is one of our 5 clinics. This clinic is on the border between a couple of neighborhoods. One's the River West, which is diverse with regard to race and ethnicity. And then the other side of the street is the Harambe neighborhood, which is almost entirely African-American. This is a highly segregated city, typical of most Midwest cities. Notice that on this clinic, there's no signage whatsoever. Speaking again to stigma around sexual orientation, sexuality, STIs, etc. Once a person swabbed, either in their home and then sent back the kit, or they went to a clinic and swabbed, then all of those were assessed for HPV genotyping, assessed for adequacy for HPV genotyping at Moffitt Cancer Center. So they came back to the Medical College of Wisconsin. They were aliquoted, several different aliquots, one aliquot sent to Moffitt Cancer Center. 12 months later, we asked them to do the same thing. Regardless of their participation at baseline, we asked them to again screen at 12 months. And then regardless of their participation in either screening, we asked them to go to high resolution endoscopy. HRA is the corollary of colposcopy in cervical cancer screening. Okay? So there's something about this and anal cancer that makes this kind of research different than cervical cancer self-sampling research. And that is the use of biomarkers. There's HPV testing and cytology that's approved for biomarkers in cervical cancer screening. There's no such approval for a biomarker for anal cancer screening at this time. So it wasn't ethical for us from a prospective research standpoint to do the sampling and then only ask those who get a positive result to go for further screening. This is why we ask everyone to go for screening in this. That's the only ethical way we could do this, we believed. All right. High resolution endoscopy is very poor infrastructure for this. In all of Wisconsin, we have one skilled high resolution endoscopist. Those recommendations for screening that just came out a couple of months ago, from that, there should be around 20,000 people in Wisconsin who should be coming for anal cancer screening. Got one high resolution endoscopist. So it's a really huge problem. It means we have to be really good at stratifying those who are at high risk versus those who are not, who are at low risk. Okay. Total of 773 people in the city were assessed for eligibility. 264 of those were not eligible. Another 227 were non-responsive. They left us their name and their phone number, but when we contacted them to say, let's set up a consenting session, no reply. Ultimately, 253 were consented and 240 of those were randomized. 120 to home-based self-sampling and 120 to the clinic-based. So age, median of 46 years, a range of 25 to 78 years of age. In terms of sexual identity, 84% identified as gay. In terms of race ethnicity, 66% identified as white non-Hispanic, 19% as Black, African-American, non-Hispanic, and 13% as Hispanic, Latino, Latinx. And 27% were living with HIV. So what about adequacy? We got these specimens, these swabs coming from self-sampling and from the clinician doing the sampling in a clinic. Very high specimen adequacy, regardless of whether it's self-sampling or clinician sampling, over 90%. Jenna Nikowski, postdoc who worked a lot on these data, she's the one that looked at temperature and whether or not high temperatures or low temperatures that those self-sampling kits experience, there was no association between temperatures and the adequacy of the specimen. There was an association, a borderline association, let's say, between the presence of a lot of fecal matter on the swab and adequacy of the specimen. So there's still some work to do on how we might counter that. Not sure how that's going to work yet. We also wanted to look at adequacy depending on a person's BMI and physical disabilities. Surprisingly, this is almost untouched research in cervical cancer self-sampling. I'm aware of maybe one paper that delves into issues of, okay, so you're asking people to self-sample, but we know that there are many body types around. There are issues with mobility with persons who have disabilities, but there's very little, if any, research. If you have an interest in a research career, this is one area where you might find some really fertile ground for funding. So we asked people, is it hard to position your body to do the anal cancer screening? 90% said it was easy, it was a little hard, or we have about 10% said it was moderately or very hard. Was it hard to position the swab at the opening of your anus? 17% said yes, it was hard. When we looked at BMI, it was significantly associated with increased difficulty. Those people are saying it's moderately hard, very hard, were more likely to have higher BMI. But regardless of BMI or physical disability, there wasn't a difference in specimen adequacy in this group. But I think given these numbers here, it's something that we need to keep a close eye on, and then also to follow up this research with more questions about how does physical disability impact our person's ability to self-screen. So then we next look not just at adequacy, but did the same genotypes, HPV genotypes, were they found in the same individual if they self-sampled or if a clinician did the sampling. So let me back up a second. Those who were self-sampled at the baseline, we also asked them to go to a clinic after they'd self-sampled to get a digital anal rectal exam to make sure no one was coming into the study who had anal cancer. We didn't want to wait until they got HRA 12 months later to find out, oh my God, they've had anal cancer the whole way. So those individuals who self-sampled and then agreed ultimately went to a clinic within a few weeks after that. We have 2 specimens. And we see the HPV genotypes in both the self-sampling and the clinician sample very close to one another. But genotypes were quite the same. Okay, let's look at preference here. 120 persons in each arm. In the self-sampling arm, they received, we call it the pack at home. They used the swab and sent it back to the Medical College of Wisconsin. 89% did that. If they were randomized to the clinician arm, 74% did that. So there was a clear preference for self-sampling at home. But importantly, this preference is even stronger in the highest risk populations. So at baseline, we're looking at preference for sampling by HIV status. For persons who are HIV negative, it didn't matter if they were randomized to the self-sampling arm or to the clinician arm. A high proportion of them screened, and there was no difference in the two arms. But if a person was living with HIV, they were much more likely to screen if they received a kit at home than if they were asked to go to one of those 5 clinics. They could choose whichever clinic they wanted to go to, but if they happened to be in that arm, they were just much less likely to screen. Same thing in terms of race. If a person identified as white, non-Hispanic, it didn't matter if they were in the self-sampling arm or the clinician sampling arm. Approximately the same proportion screened. But if a person identified as Black or African-American, non-Hispanic, there was a big difference. 95% screened. That is, they sent the kit back if they were in the home arm, whereas 63% ultimately went to a clinic to screen. I think the numbers are too low with regard to Hispanic people to make any conclusions about that. So remember, we're ultimately interested in annual screening. So what happened 12 months later? In terms of persons with HIV, we see the exact same thing happening. If they're in the self-sampling arm, they're much more likely to self-sample again. But if they were randomized, if they're a person with HIV and they're randomized to the clinician arm, only 22% of them screen at the 12-month screening. If a person was HIV negative, it didn't matter. And we see the same thing going on with race and ethnicity. If they're white at 12 months, it doesn't matter. Same proportion of screening. But if they're Black, non-Hispanic, it made a lot of difference. Okay. What about acceptability of the screening? On the left-hand side, again, home continues to be in blue, the home self-sampling, clinician sampling in orange. We asked the person, well, what's your overall thoughts about the screening experience? Just a general question. 70% or so in both arms said, hey, it was pretty good. And around 25% were neutral in each of these arms. When we asked about their comfort with the method, either the self-sampling or the clinician sampling, a high proportion of them said, yeah, it was comfortable. I'm okay with it. In terms of pain, around 1/3 said that it was a little painful or a lot painful, no matter whether it was self-sampling or clinician sampling. And then in terms of future willingness, 98, 99% of persons said they'd be willing to do it. But you always have to remember that these are individuals who decided to get into a study. That's a different population than the population at large. However, remember, we are randomizing persons to each of these arms. So that helps us have a little bit clearer picture of some factors that might be associated with self-sampling or clinician sampling. I think an important lesson from this slide for us was that if a person screened, if they just started the screening process, whether it was self-sampling or in a clinic, they were okay with it. For the large majority of these individuals, they had never done any kind of anal self-sampling before. But if they did it, they said, oh, well, this isn't so bad. Okay. All right, what about clinical follow-up? Again, 120 in each arm. These are the pies you saw earlier with a higher proportion going for or doing the self-sampling. But then, of course, we asked persons to go to high-resolution endoscopy at the end of the study, about a year later. In the blue, we see that's the home arm. We saw 52% of persons go to high-resolution endoscopy at the end, whereas 59% of persons in the clinic-based arm went to high-resolution endoscopy. It's not statistically significant, but these numbers are too low, I think, to draw any kind of firm conclusions from this. But at this point, we just have to study this more. It's very possible that a person who starts the process in a clinic is ultimately going to be more comfortable going to high resolution endoscopy, which has to happen in a clinic. Okay? So there's more to be learned about this. But when we look at HRA engagement by HIV status, as we looked at it previously, Here, persons with HIV are in green, HIV negative are in blue. And you can see overall, there's really no difference in who went to HRA based on HIV status. But for persons in the home who did the self-sampling, whether or not they were positive or negative, the same proportion went for HRA. But if they had been randomized to a clinic and they were HIV positive, they're much less likely to go for HRA at the end of the study. Okay? So this is, I think these are clues. This is like the hypothesis generating part of the study, where we take these and we say, hey, this is interesting. We need to follow this farther with a new study. And that's what we're doing at this time. So finally, we wanted to look at biomarkers. Right now, as I mentioned earlier, there's no biomarker that's approved for anal cancer screening. High-risk HPV testing, it's something that's being done in cervical cancer screening right now. So we wanted to look at that in the PAC self-swab study. The individuals that are represented here are those who went for high-resolution endoscopy, and therefore we have a histology result. So we want to know what's the sensitivity and specificity of high-risk HPV testing in these two arms, self-sampling and clinician sampling. So in that second column there, in terms of sensitivity, whether the person was doing self-sampling or clinician sampling, there's a high sensitivity for high-risk HPV. But specificity is really, really poor for high-risk HPV testing. And this is why recently, when the Department of Health and Human Services agreed or recommended that screening for anal cancer should happen, they said it should not start with high-risk HPV testing. International Anal Neoplasia Society, it's the people who kind of drove these recommendations to begin with. They do believe high-risk HPV testing has a role in beginning the screening process. But I think the important point to take away from here is that in both arms of the study, we see high sensitivity for high-risk HPV, but terrible specificity. So we need a much better biomarker. So we are in the study also looking at methylation. So methylation is the attachment of a methyl group to spots of DNA called CpG sites on the DNA, where it is more likely to see methylation. It's clear in a variety of different cancers, whether it's cervical cancer, colorectal cancer, that there are certain patterns of this methylation on human DNA, and in this case on HPV, but there are certain patterns that indicate this person could be at higher risk. In cervical cancer screening, the disease progressed from no HPV infection to low-grade lesions to high-grade lesions to cancer. It maps beautifully, methylation scoring does, with the methylation going higher. So we wanted to know, does it work, in this case, for anal cancer screening? So the thing with the S5, it's using a human tumor suppressor gene, EPB41L3, looking at methylation pattern there, in addition to looking at methylation patterns on types of HPV, HPV 16, 18, 31, and 33. So first of all, we wanted to know if persons in the self-sampling arm are getting DNA that has the quantity in order to do methylation testing. And you can see whether or not it was a clinician doing the sampling or the self-sample, similar amount of DNA yield. There's no significant difference there. But then also the quality of the DNA. Is there a difference in the quality? A random sample of 36 individuals were taken from this 132, and when a quality assay was assessed, there was no difference between self-sampling and clinician sampling. So then let's look at these anal samples and whether or not there is disease progression. And we see there is disease progression in the clinician samples, particularly from persons on the normal end of the spectrum on the left-hand side through to AIN. AIN is anal intraepithelial neoplasia. This is the corollary of CIN in cervical cancer. You can see there's increasing methylation scores until finally the one individual in the study who had cancer, their methylation score is here at the very top. For self-samples, the progression is not as clear and as prominent as we see with the clinician samples, but it's still there. So this is an area that we want to pursue more. This is important because if we want to have people screening in the home, they have to have non-hazardous substance used with a test that goes into the home. We can't do cytology in the home. It's a hazardous substance that's used with cytology. But with methylation, you can send it into the home with standard transport media, which is what we used in this study, and still be able to get a methylation score. So we and many, many other people are very interested in methylation as a screening. So what are next steps? How do you implement home-based self-screening into a fragmented healthcare system like we have in the United States? There's huge opportunities here for implementation science. If you have an interest in that, then this is an area that I think there's fertile ground for learning a lot. Will the home-based self-samplers have comparable attendance at subsequent clinic visits? This is still an open question. We see a promising signal in this study, but it is not a settled question. And then what biomarkers are going to have good sensitivity and specificity? So takeaways from this. When we think about equity-based anal cancer screening and giving opportunities to individuals, diverse individuals across the population who would need to do anal cancer screening, I think this clearly says we need to give options to individuals. Okay. Self-sampling is likely going to result in increased engagement compared to clinician sampling. We think this is especially the case for people with HIV and also Black MSM. Home-based self-sampling, it may have comparable attendance to subsequent clinic visits. And then HIV testing, it probably differs little with self-sampling or clinician sampling, but again, it's not a great biomarker because there's already so much infection at the anal canal in those who are at highest risk for anal cancer. But then the quality and the quantity of the DNA methylation test is a promising signal and something that we want to follow up with. So that's the end of the talk. I'm glad you'll listen to this. Thanks a lot for inviting me.